So we're back. So thanks everyone for coming back online with us. I'm very excited and honored to introduce our keynote speaker, Dr. Andrea MacNeill, who is joining us from the West Coast. She is a surgical oncologist and general surgeon at Vancouver General Hospital. She's also an associate professor at University of British Columbia. And she's joining us today to talk about designing sustainable health systems for patient, public, and planetary health. And she's really been a pioneer in this field. She's published many landmark papers and really is a world expert on this. So we're super happy to see her and that she was available to join our meeting today. Thanks so much, Andrea. I'll pass it over to you.
Thank you, Tim. And thank you to Jennifer and to the organizers for inviting me to join you today. I was asked to give this address more than 9 months ago when the world was a very different place. And I appreciate OAGS honoring that commitment because COVID has actually made this more timely than ever. The disruption of the past 9 months has been unprecedented in all of our lifetimes. COVID has changed the way we work, educate, deliver healthcare, travel, and live. This disruption, in combination with the trillions of dollars of relief and stimulus packages, have really set the stage for a global reset, a chance to rethink how we structure our society and to chart a new course for decades to come. In May, an open letter to the leaders of the G20 was signed by 40 million health professionals, or 2/3 of the global healthcare workforce, advocating for a healthy recovery and calling attention to the ways in which human health is dependent upon a healthy environment. Antonio Guterres, the UN Secretary General, argued in a New York Times opinion piece in April that this is an opportunity to build more sustainable and inclusive economies and societies. He proposed a suite of climate positive actions that governments should include in their pandemic responses. The WHO published a manifesto comprising 6 prescriptions for a healthy recovery, including heightened environmental protections, sustainable food systems, healthy urban design, clean energy, and an end to fossil fuel subsidies. Everywhere we're seeing calls not to return to quote unquote normal, but to build back better. The pandemic has shone a spotlight on the field of planetary health, which is a relatively new area of study, and it's a collective term that encompasses both human health and the natural systems that underpin them. Even at the peak of the first COVID wave, the head of the WHO, Tedros Ghebreyesus, refused to view the pandemic as unrelated to planetary health, saying that any efforts to make our world a safer place are doomed to fail unless they address the critical interface between people and pathogens and the existential threat of climate change. Now, just as governments must make decisions on a societal level that determine population health, so healthcare organizations have an opportunity to map out a healthy recovery. This includes reimagining the way we deliver care, how we interact with our local community, and the impact of our organization on local and global environments. It's a unique opportunity to embrace our mandate to not only treat disease, but also create health and promote wellness. A healthy post-pandemic recovery for health systems should embed planetary health principles in our organizational structures and in our everyday activities. So what's the scope of the opportunity here? Healthcare is responsible for 4.6% of global greenhouse gas emissions. And this may not sound like a lot, but to put it in context, aviation is responsible for 4.9%. So decarbonizing healthcare would be equivalent to eliminating air travel altogether. If the health sector were an independent country, it would be the 5th highest emitter in the world. In addition to climate impacts, healthcare activities generate pollution, massive amounts of solid waste, and uniquely toxic biohazards that contaminate soil and water. The US was the first to publish national estimates of healthcare emissions, and they found that healthcare is responsible for a full 10% of all greenhouse gas emissions in the US. The public health damages estimated to result from this level of pollution are approximately 614,000 disability-adjusted life years, which is on par with the harm caused by medical error. But while a billion-dollar quality improvement industry has arisen to mitigate the threat of medical error, that same attention has not been devoted to healthcare's environmental footprint. The authors conclude that healthcare pollution should be considered a patient safety issue and be incorporated into quality improvement efforts. In 2018, we became the 3rd country to publish our national healthcare emissions, coming in at 4.2%. And while in absolute terms, this may be on par with the global average, we actually have the third highest healthcare per capita healthcare emissions in the world. These data are from the 2019 Lancet Countdown, which is an annual reporting structure on a number of climate and health metrics. And the finding was so significant that it was highlighted as one of the top 3 actionable issues for Canada in the accompanying policy brief. Our recommendation was the creation of a multidisciplinary pan-Canadian initiative to chart a course toward net zero healthcare emissions. Only 2 months later, in January of this year, the NHS announced a commitment to decarbonize well in advance of the nationally mandated target of 2050. And this has set a powerful precedent for other health systems. Myself and Fiona Miller, who's a professor of health policy at U of T and the founder of the Centre for Sustainable Health Systems, are working with the architects of the NHS campaign to lobby for a similar commitment from both federal and provincial governments in Canada. So the logical next question is, how do we get to net zero? And what does a sustainable healthcare system actually look like? The answer is first and foremost, not recycling, which is the universal visceral response and a source of great frustration for myself and others in this space. If we want to take meaningful action at the scope and scale required to avert catastrophic climate change, we have to do a whole lot more than sort our garbage into different bins. So I'm going to present to you a 3-tiered approach to sustainable healthcare that begins way, way upstream from the recycling bin. The first thing to understand is that every healthcare activity has a footprint. So every test you order, every treatment you provide consumes energy and materials and generates waste. So the highest yield strategy for reducing the healthcare footprint is to reduce the demand for health services. This brings us back to the idea of a healthy post-pandemic recovery and the way that the decisions made today will determine the health of our society for years to come. The WHO recommends a health in all policies framework in which decisions regarding transport, housing, employment opportunities, and livable incomes are all informed by their impacts on population health. The healthier people are, the less reliant they'll be on healthcare systems, which is the biggest determinant of both the environmental and economic sustainability of those systems. So here are some examples of primary prevention strategies that reap simultaneous co-benefits for people and the planet: promoting health and reducing the demand for health services, encouraging active transport like cycling or walking with supportive urban planning and organizational structures like commuter centers leads to obvious health benefits like reduced diabetes, obesity, cardiovascular disease. Furthermore, they enhance urban air quality, leading to decreased respiratory illness and cardiovascular disease. One of the possible benefits of the pandemic is that the expanded access to active transport infrastructure might persist, with many cities permanently expanding their cycling and pedestrian infrastructure and banning cars from city centers. The new Canada's Food Guide has been celebrated for its evidence-based recommendations and adherence to a planetary health diet, with emphasis on plant-based proteins, portion control, and even the sociocultural aspects of eating. Widespread access to proper nutrition and adherence to recommendations like these would be expected to impact on the burden of obesity-related illnesses, cardiovascular disease, and cancer. Food security and resilient food systems have emerged as a top issue from COVID, as loss of income and disrupted supply chains have threatened many people's access to adequate nutrition. Hospitals are huge consumers of food and have an enormous opportunity to leverage that to create health for their patients and staff, and also value for the local economy. And I'll speak more to this later. Policies that reduce greenhouse gas emissions improve cardiorespiratory health and reduce cancer incidence. The Canadian Association of Physicians for the Environment, under the leadership of its past president, Courtney Howard, shown here, was one of the key driving forces behind the federal government's accelerated coal phase-out, which is a commitment to decommission all coal-fired power plants in Canada by 2030. And in their description of the policy on the government website, they specifically cite the anticipated health benefits and recovered healthcare costs as rationale for the decision. In June, the International Renewable Energy Agency released this roadmap for an accelerated clean energy transition as part of a healthy recovery, showing that investing in low carbon energy infrastructure now would be job creating and would stimulate the economy much more than ongoing oil and gas subsidies. The cost of investment would be recovered 8-fold by the healthcare system. Secondary prevention is the next most impactful level of intervention, because by detecting disease early and preventing its progression to a more advanced form, this reduces the intensity of care required. And cancer screening programs are good examples. Think about the cost to the patient and to the system of treating a colonic polyp as opposed to a colon cancer. Cost of care is usually a good proxy for environmental cost because it reflects resource intensity. A colonoscopy and polypectomy cost the system about $600, whereas the average cost of colon cancer treatment in Canada is $44,000 and includes all of the material resource use of surgery, often chemotherapy, and in the case of rectal cancer, radiotherapy. This raises important issues about health expenditures and the current proportion of healthcare funding that's devoted to advanced therapeutics that buy marginal gains in quantity or quality of life over investments in primary and preventive care. Hemodialysis is an area that's actually been well studied from an environmental perspective. The carbon footprint of hemodialysis is between 3.8 and 7.2 tons of CO2 equivalents yearly, which is analogous to driving a car 28,000 kilometers. It's also a costly intervention from a health system perspective at $60,000 per patient per year. Imagine if some of those resources were redirected into primary care for better chronic disease management so that some patients never progress to end-stage renal disease. This is obviously a better patient outcome as well as better for the health system and the environment. The next principle of healthcare sustainability is matching supply to demand. And by this, I mean matching the intensity of care to the problem being addressed, which can also be thought of as ensuring appropriateness of care. Our first maneuver should be to eliminate care that adds no value whatsoever. A 2017 report from Kai Hai and Choosing Wisely indicated that 30% of care delivered in Canada is unnecessary. This includes both investigations and treatment, such as people undergoing low-risk procedures who have unnecessary preoperative tests, people prescribed antibiotics for viral infections, or people who underwent surgeries that were not indicated. And it also provides a cautionary tale about managing innovation, such as the introduction of robotic surgery for procedures in which there's no demonstrated benefit over laparoscopic surgery. I mentioned the Choosing Wisely campaign, and I want to expand on this. Choosing Wisely is an international initiative to advance a dialogue on avoiding unnecessary medical tests, treatments, and procedures. They've partnered with over 80 medical specialty societies to devise evidence-based recommendations for the appropriateness and necessity of given tests and treatments. This approach to ensuring high-value care is captured in the notion of stewardship, which we're most familiar with as it relates to things like antibiotic or opioid prescribing, but should be extended to stewardship of all healthcare resources. We undertook a study around stewardship of laboratory investigations in general surgery at Vancouver General Hospital, and this can serve as a prototype for the kind of critical review that could be undertaken by every specialty or community of care. The work was done by two of our general surgery residents, Annie Lalonde and Karina Spoyalo. They looked at blood work in a subset of our acute care general surgery patients. As shown here, unnecessary blood work has cost to the patient, to the hospital, and the planet. We identified populations of bread and butter acute care general surgery, appendicitis, biliary stone disease, and small bowel obstructions, and we established what we felt were ideal ordering pathways. So this includes things like not ordering postoperative blood work in patients who undergo uncomplicated appendectomy or cholecystectomy and are going to be discharged home within hours, and no trending lipase in gallstone pancreatitis. We then compared the actual blood work performed to these ideal pathways and found that 76% of patients underwent unnecessary blood work. In this small population of select general surgery patients, we performed 1,200 unnecessary blood tests per year at a cost of $10,000. And when we extrapolated these results to the whole hospital, we estimated that VGH disposes of 58,000 excess plastic blood vials yearly from tests that add no value. We're now working to develop best practice guidelines to encourage this sort of resource stewardship across the specialty. Unnecessary care also arises because of the way we design our health systems. An informative example can be found in rare cancers. Dr. Seetha Aulick recently graduated from our surgical oncology fellowship program, and she looked at patients across BC with retroperitoneal sarcomas. These patients typically present to their family doctors or their local emergency departments, and they're referred to a local surgeon of any number of specialties, who typically orders an array of tests and may even undertake exploratory surgery, and then they're referred on to another specialist until eventually they reach definitive care. We found that some patients saw up to 7 specialists before arriving at their definitive treatment provider. Virtually all had unnecessary testing, including 27% who underwent unnecessary surgery at a median excess cost of $20,000 per patient. Unsurprisingly, this circuitous process results in delays in accessing definitive care, with median time from first presentation to treatment being 14 weeks. So we're now working to implement clinical pathways to expedite these patients' arrival at definitive care and eliminate all unnecessary steps, which will not only result in cost and carbon savings, but also provide more timely care, improve the patient experience, and potentially improve their oncologic outcomes. The next dimension of ensuring appropriate care is eliminating unnecessarily intense care. This involves adequately funding primary and community care so that people aren't using emergency departments for want of a family doctor, and funding long-term care so that we don't have elderly or debilitated patients occupying acute care beds for long periods of time awaiting placement. It also involves aligning incentives within the healthcare system. Fee-for-service physician remuneration models incentivize high volume rather than quality care. If we want a system that encourages appropriate care, we need equal financial incentives for non-operative and operative management. And finally, virtual care offers the ability to respond to patients' needs via an appropriate communications medium. Virtual care is a hallmark of a sustainable healthcare system because it displaces more resource-intensive in-person interactions with remote communications. This includes both synchronous communications, which are real-time interactions either by phone or video platform, or asynchronous communications like email or text messaging. Virtual care can be facilitated by EMRs with enhanced remote communications capabilities and mobile apps that can potentially avert the need for a clinic visit with a quick messaging exchange between the patient and their provider. Multiple studies have shown these to be more convenient for patients and more cost-effective than in-person care, to say nothing of the avoided emissions of travel and resource utilization. Some of you may have experience with the app developed in Toronto that allows breast cancer patients to upload photos of their reconstruction for regular review by their plastic surgeon in the early post-op period, thus avoiding repeated clinic visits. The CMA's Virtual Care Task Force commissioned a survey in 2018 that showed that only 8% of Canadians had access to a physician using virtual care. New survey results from June 2020 show that during the first 2 months of the pandemic, that number had risen to 57%, and that the satisfaction rate with these interactions was 91%. 38% of patients surveyed would prefer to maintain this option. One of the many positive legacies of the pandemic will be enhanced virtual care platforms, and I sincerely hope that clinicians choose to maintain these options going forward. This brings us to the third principle of a sustainable healthcare system. Once you've ensured the appropriateness of care, then you can focus on optimizing the environmental performance of the care required. This includes the environmental performance of the buildings and infrastructure of the healthcare system. In BC, we're fortunate to have BC Green Care, which is an amalgamated team across the Lower Mainland health authorities who work on energy and waste management. Under their leadership, our greenhouse gas emissions have decreased almost 20% since 2007, and energy intensity has declined 13%. But while the engineers and sustainability consultants have done a phenomenal job with their mandate, there's still a gap to bridge with the clinical community and a need for frontline workers to understand the environmental consequences of their clinical decisions and to be empowered to take meaningful climate action within their professional spheres. Environmental sustainability is a component of high value care, which is a paradigm that's gaining traction with clinicians and senior leadership alike. This takes the well-established notion of quality of care and incorporates cost. A high-value care paradigm recognizes that we do not live in a world of infinite resources. Costs of care that should be internalized include not only financial costs, but also environmental costs and public health damages. Michael Porter from Harvard Business School is a thought leader in organizational strategy and one of the fathers of value-based healthcare reform. In this boldly titled manifesto, he suggests that healthcare would be better organized around the integrated treatment of disease rather than individual professional practices. My own division of general surgery at VGH has embraced this model, and under the leadership of Dr. Morad Hamid, we've reorganized into integrated practice units in which team-based care is delivered in a way that streamlines and optimizes the patient experience and outcomes. The paradigm includes familiar concepts like multidisciplinary clinics that allow a patient to see multiple specialists or allied health providers in a single coordinated visit instead of multiple individual trips. I undertook a Master's of Environmental Change and Management in order to investigate the environmental performance of the operating room. And the result was this study published in 2017. I'm going to show you some of the main findings and some of the actions that came of it. And I would encourage you all to be thinking of further actions we could take. We conducted a greenhouse gas inventory of operating rooms at 3 well-matched tertiary care academic hospitals, VGH, the University of Minnesota Medical Center, and the John Radcliffe Hospital in Oxford. The study was carried out according to the Greenhouse Gas Protocol, which is the industry standard for carbon accounting and reporting. The protocol recognizes 3 scopes: emissions that come from directly within the organization, which in the OR is exclusively waste anesthetic gases, emissions due to energy consumed by the organization, and all other indirect emissions that go into the manufacture, use, and disposal of the consumables that are used by the organization. Inhaled anesthetics are greenhouse gases. Their potency is expressed as a global warming potential over a 100-year time horizon relative to CO2, which is assigned a value of 1. The global warming potentials of the 3 currently used inhaled anesthetics, SIVO, ISO, and desflurane, are 130, 510, and 2,450 times that of CO2. We took the purchased volumes of each agent over 1 year and calculated carbon footprints. The 2 North American sites had very similar emissions profiles at about 3 million kilograms of CO2 equivalents each. But notice that in spite of a much higher case volume, the UK hospital's anesthetic footprint was only 10% of the others. This is due entirely to differential use of desflurane, which the UK hospital didn't even have on formulary because of cost. ORs require energy for heating, ventilation, and air conditioning, lighting, and all other electrical devices, which are collectively termed plug loads. We measured energy consumption due to HVAC systems, carried out lighting audits, and submetered the ORs at each site to calculate an energy footprint. The left half of this table shows energy consumption in megawatt hours per year. VGH and UMMC were similar, while JRH had considerably higher energy consumption due to the larger size of its surgical suite. But in spite of similar energy consumption, the carbon footprint at UMMC was 3 times that of VGH, and this is owing to differences in carbon intensity of the electricity supply. Minnesota's electricity is mainly coal-fired, while BC has some of the cleanest electricity in North America. The 20-fold difference in carbon intensity in the electricity supply accounts for nearly all of the million kilogram difference in carbon footprint seen here. Now, on average, HVAC requirements account for 50% of hospital energy consumption, but operating rooms have the highest HVAC standards of any area in the hospital, requiring 20 air changes per hour as opposed to 6 in a patient wardroom. As a result, HVAC requirements account for 90 to 97% of operating room energy use, which is helpful in directing energy conservation efforts. An accurate measure of the greenhouse gas emissions attributable to a product must take into account its full life cycle, from the extraction of the raw materials to its manufacture, use, reuse if applicable, and ultimately its disposal. We did a lot of work on waste in this study, including waste audits showing that VGH ORs generate 1,200 kilograms of waste daily, and we tracked the waste downstream to all of the processing facilities to calculate really granular carbon footprints. Ultimately, both at VGH and in Oxford and Minnesota, we found that emissions from manufacturing far outweighed emissions from waste management. These are the cumulative carbon footprints. The 3 sites each emitted between 3,000 and 5,000 tons of CO2 equivalents yearly. In North America, anesthetic emissions predominated, whereas in the UK, energy consumption was the main source of emissions. If we were to assume that the hospitals studied were representative of their respective regions and we extrapolate the findings here, ORs will be responsible for 9 million tons of greenhouse gas emissions annually, which is equivalent to 2 million cars on the road for 1 year. Now let's talk about actions taken since this study to lessen our footprint and what areas need further attention. Desflurane has long been known to have a disproportionate climate impact. And in 2012, one of my anesthetic colleagues at BC Children's Hospital undertook an educational tour of local anesthesia departments to advocate for preferential use of sevoflurane instead. In 2018, he published this editorial showing that in 7 lower mainland hospitals from 2012 onward, emissions due to waste anesthetic gases fell from 13.4 million kilograms of CO2 equivalents to 4.5 million. This is an astonishing result from a single intervention, and it speaks volumes to the engagement of our anesthesia community in environmental stewardship. Even better is avoiding volatile agents altogether. This is work that my colleague Jody Sherman and her group have done at Yale, comparing different anesthetic strategies. And without going into any detail, you can readily appreciate that anesthetics that involved inhaled agents, shown in the top two bars, have significantly higher global warming potentials than techniques such as TIVA, spinal, or regional anesthesia. At BC Cancer, we now carry out almost all of our breast cancer surgery under regional. This not only minimizes climate impact, but it avoids post-op nausea and vomiting, minimizes recovery time, and it eliminates the need for post-op opioid prescribing, which is another public health win. Another important finding in our study was in the area of energy conservation. We discovered that many hospitals don't titrate ventilation to usage of clinical spaces, and ORs are often aggressively ventilated when not in use. We modeled scenarios in which the maximum number of ORs not in use were scaled back to 8 air changes per hour instead of 20 after hours, and we found that we could cut energy consumption by half. When we talk about sustainability, many people default to thinking about waste management, but we now know that up to 90% of a product's emissions are generated in the manufacturing phase. So the choice of consumable matters far more than how it's disposed of. It's time to move from the concept of waste management to waste avoidance, with the ultimate goal of zero waste. I want to familiarize you with the concept of circular economy. A linear economy is one in which raw materials are extracted and manufactured into products that are used once and discarded. In contrast, a circular economy involves a cascade of loops that keep products in circulation at their highest value for as long as possible. And this is a hierarchy of loops, with reuse being the best option. An example of this is steel surgical instruments that are steam sterilized and reused for decades. Some products need refurbishment or repair to keep them in circulation, and when no longer suitable for their original purpose, can be repurposed for other applications. The lowest value loop is recycling, which only recovers the base materials, and it requires considerable energy and material inputs. So recycling is not a panacea, and it does not absolve a person or an organization from its environmental responsibilities. Up to 70% of healthcare emissions originate in the supply chain. So this is the area where we can have our greatest impact. We need to be actively countering the trend towards single-use everything, because a linear economy is just not compatible with a finite natural resource base. Some of my colleagues from plastic surgery are investigating the application of circular economy principles to a specific aspect of breast surgery. When placing breast implants, whether for augmentation or breast reconstruction after mastectomy, silicone sizers are often used as temporary placeholders to determine the optimal implant. Every year in Canada, approximately 30,000 silicone sizers are disposed of after one use. Now, the first principle of circular economy is reduction. So questioning whether the material use can be avoided altogether. And in this case, it can, with careful preoperative biodimensional planning, including software sizing to anticipate the correct implant. The second principle is reuse. Sizers are approved for reuse, but for various reasons, it's not often done, but it could be undertaken to extend the lifetime of each product and minimize the number being discarded. And finally, if a single-use device is deemed necessary, an environmentally preferable option should be selected, which in this case would be an air-filled sizer rather than one filled with silicone. This hierarchical approach to material use is emblematic of the way we should all be critically evaluating our clinical choices. Many studies have documented the staggering magnitude of environmental savings from reusable medical products. Single-use surgical gowns consume 2 to 3 times as much energy, emissions, and water as reusables, and generate 7.5 times as much solid waste. And these provide an excellent example of how products can cascade through these reuse cycles. Gore-Tex gowns are approved for 75 uses before they're no longer suitable for high-level barrier protection. But after this, they can be repurposed as non-sterile PPE for isolation rooms or endoscopy, and they can be washed hundreds more times before they're no longer usable as gowns, at which point they can become fiber fill for upholstery or insulation. The environmental benefits shown here only take into account the 75 life cycles as a surgical gown, so you can imagine that these are amplified many more times when used in a true circular economy. Another study out of Yale compared reusable to disposable laryngeal mask airways and found that disposable LMAs generate 50% more emissions than reusables. Importantly, life cycle assessments like this take into account not only climate impacts from greenhouse gas emissions, but other environmental impacts like ozone depletion, water use, and air pollution. Disposable LMAs had higher impacts in every category, the most striking of which was carcinogens, with reusable LMAs generating only 5% as much as disposables. The vulnerabilities of a linear economy were laid bare by the pandemic, in which a shortage of PPE was the result of these items being single use. Consequently, the only way to scale up supply is to purchase more, such that disruptions in manufacturing, in transportation, and even in international trade jeopardized hospital supplies. In contrast, had hospitals been equipped with reusable gowns and respirators, they would have only had to scale up their reprocessing cycles, which is typically a local phenomenon and much more easily done than scaling up manufacturing. Many hospitals, including my own, developed reprocessing protocols for items that are meant to be single use, like N95s. And while this is laudable, even better than ad hoc reprocessing protocols would be purpose-built, durable, reusable products that are designed for longevity and performance. With all of these basic principles in mind, the role of health promotion and disease prevention, ensuring appropriate high-value care, and optimizing our environmental performance, I want to share with you my thoughts for how healthcare organizations can map out a healthy post-pandemic recovery and embed planetary health principles in all of our operations so that we can deliver high-quality, low-carbon care that is resilient to future disruption. I'm pleased to be working with my own health authority on developing and implementing this plan, but it has been specifically crafted to be universally applicable across health systems. The 5 pillars of the plan are hospital food transformation, integration of environmental metrics into quality reporting, stewardship, a circular supply chain, and clinical services mobilization. Annie Lalonde, the general surgery resident I mentioned earlier, has just begun a 2-year master's in the Institute for Resources, Environment, and Sustainability at UBC to look at the environmental and health benefits of implementing a planetary health diet for inpatients. We are partnering with executive chef and founder of Chefs for Oceans, Ned Bell, who also competed on Iron Chef Canada, to develop an inpatient menu based on planetary health guidelines, and we'll trial this in a select population of general surgery patients. In addition to capturing the environmental benefits, we're going to look at patients' nutritional parameters, their short-term post-operative outcomes, and their experience. And there's also a longitudinal component in which we provide patient education on the environmental impacts of food choices and follow up several months later to determine whether they've altered their dietary behaviors. The menu will be developed with a view to maximizing local procurement in order to invest in BC growers and leverage our purchasing power to create social value. Our quality and patient safety team is investigating how we might embed environmental performance in quality reporting in order to convey that this is an internalized cost of care with public health implications. This might include mandatory reporting of resource utilization and waste generation for quality improvement initiatives. We're working to expand the existing stewardship program beyond antibiotic stewardship, and we're on the brink of implementing an automatic 3-day stop date on daily blood work, such that blood work orders have to be routinely reviewed and reordered just as they do for antibiotics and opioids. One of our neighboring hospitals has had this in place for some time with significant savings and high levels of provider satisfaction. Developing circular supply chains requires procurement policies that prioritize reusables, engaging with clinicians to have everyone critically review their habits and drive demand for reusable products, and engaging with industry to develop better reusable devices. Now, these 4 pillars are universally relevant across all clinical communities and specialties, but we also need a mechanism for healthcare providers to identify areas of waste and inefficiency in their specific practices and to tailor solutions to their individual clinical contexts. To this end, we've just launched a pilot initiative to mobilize the OR community at VGH around environmental sustainability. We have an online platform called Spark to crowdsource ideas for ways in which we can lessen our environmental footprint. And this is accessible to all of our surgeons, anesthetists, nurses, PAs, housekeepers, perfusionists, etc. People can comment or vote for ideas they endorse, and we have moderators who monitor the site and evaluate ideas according to environmental impact, feasibility, and clinical impacts. It's like a combination of Yelp and Twitter for OR sustainability. We've committed to implementing 3 ideas and to studying and communicating back the environmental savings to our OR community. If this proves to be an effective process, we'll roll it out across the health authority so that each clinical community can identify their own opportunities and priorities. Now, regardless of your respective institution's commitment to planetary health, you all have the ability to take meaningful climate action within the scope of your day jobs. I would encourage you all to think about the concepts discussed today, to go beyond replacing the light bulbs, and really critically evaluate the way you organize your practice, the clinical decisions you make every day, and the things you use to do your job where you can make a lasting impact. Just like COVID, climate change is a global public health emergency that requires urgent, coordinated action based on science and healthy public policy. We've been told for years that the solutions to climate change were too complex and that it was too ambitious to expect major structural changes within a decade. COVID has shown us that it can be done. Through the most impressive coordinated action and collective mobilization of our lifetimes, we flattened the first wave of the COVID curve in Canada, and we avoided the carnage we witnessed elsewhere. Now, on the alarming upswing of a second wave, we've been asked to rally again and continue to buy time until a vaccine can restore some sense of normalcy. But there will be no vaccine for the ecological collapse we're seeing around us. It's time to apply this same pandemic effort to resuscitating the health of our planet and to flatten the climate curve. Thank you all for your attention. I'm very happy to take questions.
Thanks so much, Dr. McNeill. That was a fantastic talk, and certainly very eye-opening for sure. I love the way you have a practical approach, not just highlighting the problem, having the 5 pillars. And I think it was something I was really wrapping my head around, trying to figure out what can I do on Monday to move the needle on any one of those pillars. And so thank you for that. And we do have some questions rolling in here for you, and I don't know if you can see the screen, but I guess thinking about sort of what do we do next week about this, I think we all agree that we have a huge opportunity here and that we are part of the problem. This question sort of lines up with that sort of, what do I do? So it's Dr. Nala Panini here. She says, how can we reduce wastage if we cannot even get regularly used instruments in reusable material? So she says, example, no more reusable anoscopes and barren ligators. So yeah, it's practical. It's when the rubber hits the road. What do we do?
Well, that's kind of why there's a hierarchical approach, and optimizing the environmental performance of the healthcare system is the third of those tiers. So we need to engage with our institutions and our purchasing providers to try to ensure that we have a full suite of reusable options. But to the extent that we have choice, we can select the reusables. But even better than that is questioning whether they're necessary in the first place. So ensuring that we are recommending appropriate treatment, that we're not doing unnecessary tests and treatments. And then, yeah, engaging with our trainees and the rest of our clinical communities to just ensure that we have streamlined care as much as possible, so that we're eliminating that top 30% of healthcare that is absolutely unnecessary. That in and of itself will be more impactful than switching to reusable anoscopes. Ultimately, that's where we're headed. That is the goal, is to have an entirely circular supply chain. But I realize that that is a medium to long-term goal. In some cases, there are options available, and it's a matter of convincing your organization to supply those. And in other cases, we actually have to engage with industry. That's the longer term time horizon, to send a signal that we want reusable products and to drive the R&D that needs to happen around that. And to really convey that those companies that come out with purpose-built, reusable, quality, durable products will have a competitive advantage over the others.
Yeah, excellent answer to a difficult question. And other questions come up here. So first of all, lots of praise and applause for your talk. I'm sorry it's virtual. We can't be actually clapping, but virtual claps all over the place here. So here's the question. It seems that the biggest barrier to sustainability is cost. Our center always sacrifices environment for cheaper alternatives. So it seems like that's something you could flip the other way, right? So just a comment on cost.
Yeah, I mean, I hope that I've been able to show to a certain extent that this needn't be a competing priority, that if we're juxtaposing immediate financial cost with environmental cost, we are not engaging in full cost accounting, and we're not looking at an appropriate time horizon. Take the gown example. if we're looking at cost, and some hospitals have actually cited the cost of reusable gowns as a barrier, you need to be comparing the cost of one reusable gown with 75 disposable gowns. It's not one-to-one. You have to actually look at the anticipated life cycle. And that's a conservative estimate, because as I've shown, after 75 uses, that gown can still be reused probably hundreds more times. So I think a lot of the accounting that's done is extremely short-sighted, and it's actually quite spurious because it's comparing apples to oranges. Virtually every study that's been done looking at this has demonstrated cost savings with reusable products.
Yeah, and I think that's a really, really important point, because as you know, if you know, talking to administrators and things like that, making that cost argument is almost one of the first questions, right? And I was thinking when, you know, a very practical thing we could all do here in Ontario is you're mentioning about unnecessary blood work and things like that, even just engaging in the choosing wisely recommendations and adopting those just for, you know, things like pre-op testing and getting at that 30%, as you've highlighted, as sort of stuff that we do sort of just automatically for no apparent reason.
Yeah. We had our hospital take over preoperative testing, as in the pre-anesthetic clinic now orders the appropriate test for every patient. So individual surgeons don't do that at all anymore. And that has dramatically reduced the number of tests and obviously the costs associated with that. So ultimately, all we're talking about here is eliminating waste and inefficiency. We're just looking at that through an environmental lens instead of through a pure cost or lean lens, but the outcome is the same. These are all cost savings.
Yeah. No, for sure. So another interesting question here. So it says the federal government has put forward a plan to ban single-use plastics. Healthcare materials have been proposed as one of the exemptions. Is that reasonable?
That's a very good question. I think it's probably too heterogeneous of a collective to issue a judgment on. Certainly, there would be some medical devices for which there's no alternative at present to a single-use plastic construction. Again, that's where we need to engage with industry to fix that, but that certainly needn't apply across the entire spectrum of medical devices or healthcare consumables. There are many, many things we use which should fall into that category of unnecessary single-use plastics and be banned.
All right. And so I can tell you're going to get lots of invites for grand rounds all across the province. So that just watch your inbox. And okay, so here's a practical question. Who would my hospital contact to do an environmental sustainability assessment of our operations?
That is a very good question. And so there's differences across provinces. Like I said, in BC, we actually have an amalgamated team that looks at the building energy performance and some of the standard carbon accounting and reporting structures, of which clinical operations are usually not included. In Ontario, I don't know of a similar kind of cohesive unit that does that, but the Centre for Sustainable Health Systems is based out of U of T. They have a network of the academic health sciences centers in Toronto and a number of other hospitals that are starting to work together on this sort of thing. That would be probably my first point of contact is Fiona Miller at the Centre for Sustainable Health Systems. And if she is not able to kind of offer that within her current purview, she could probably direct different areas of Ontario to their local resources that would be able to do that.
Perfect. Excellent. All right. There's a lot of them have the same theme here. They all want to use your talk, so that's good. And Jen, do you see any other questions here? I kind of bounced around a little bit.
I don't think so, but I do have one for you, Andrea, and that's that you're obviously spreading this word fairly widely, and being a surgeon, you're probably spreading it to the surgical audience a fair bit, but I'm wondering how is this getting out to the anesthesia audience? Because it does sound like they can have a big impact in terms of their selection of type of anesthetic. It sounds fantastic what you're doing with the breast surgery and really promoting the blocks, but more use of TIVA, like particularly as anesthesia residents go through their training. I think it's really important for them to appreciate these differences and have an impact. So curious to know if you know how much this is getting out to the anesthesia world.
I actually think that the anesthesia community in general is ahead of us on this because desflurane has been so egregious from a climate perspective, and that's been known for several years. And much of this actually falls into their purview. The choice of anesthetic strategy, some of the consumables, there's more data around the anesthetic side than the surgical side. So for the most part, they know even more than we do. The American, I'm not going to get this right, but I think it was the American Society of Anesthesiology, or whatever their professional governing body is, has just recently incorporated environmental considerations into their clinical decision-making in a kind of professional statement, saying that staff anesthesiologists have an obligation to think about the environmental impacts of their selection of clinical choices, which is actually very powerful to have that come from an overarching body. So it is getting out there, and there's also been a lot of interest from senior medical leadership, hospital administration. So at the higher levels, the general principles are also permeating the healthcare community and reaching the decision makers. So I think all of our colleagues will hear more and more of this. It will not just be a surgical or anesthesia issue.
Great, excellent.
That's great. There's not a lot of new questions coming in. Again, the same types of themes. There's one here talking about legal liability and reprocessing devices. So I don't know, can you comment on that, or?
Yeah. So there are purpose-built reusable devices, of which surgical steel is the best example, right? That's actually meant to be reused over and over. So anything that's deemed reusable, you needn't worry about legal liability around that. Then there's those items that are manufactured as single use that undergo reprocessing. And historically, that was done on an individual hospital basis, but specifically for this reason, due to concerns around liability, hospitals now tend to outsource that to third-party reprocessing companies. So there's only a couple big players in this field, like Stryker Sustainability Solutions. They collect all the hospital's single-use devices, reprocess them, and provide them back. So because that is done by a third party for whom that is their primary business model, they absorb the liability aspect of that. So for the most part, we're not really operating outside of those structures and exposing ourselves to undue liability in using reusable or reprocessed items.
Makes sense for sure. So on that note, I want to ask you a question related to the reprocessing. So I recently had basically an education session on exactly what you just said. If there's an advanced energy device, this third-party company is going to collect it. They're going to take it to somewhere. They're going to disassemble it. They're going to wash it. They're going to put it back together. They're going to put it in a new box, and on and on and on. It's this big, long process. And to what extent do you think that is actually like saving the environment anything?
There are documented savings. The American Association of Medical Device Reprocessors, or AAMDR, has published those. So for the US, Canada, and Europe, most recent numbers were, I think, 2018. They diverted something like 400 tons of single-use devices from landfill and saved over $1 billion in healthcare expenditures. But reprocessing of single-use devices should be seen as a Band-Aid solution for sure. I mean, that was never the intent for which these devices were manufactured. You face an uphill battle in convincing clinicians that they are functionally equivalent after they've been disassembled and reprocessed. And by far and away, the better alternative is to drive industry to provide us with purpose-built reusables.
Yeah, perfect. So that was a great answer. I have my answer there. So staggering numbers. This was an interesting comment too, just came in. So many organizations previously cited better infection control for single use compared to reusable, gowns, drapes, instruments. Any thoughts on that?
I have a lot of thoughts on that. Some of which I can't articulate in this environment.
Oh.
But it is entirely greenwashing equivalent to whatever the infection control equivalent of greenwashing is. There is no documented infection control advantage to single-use devices if properly reprocessed. And while there have been individual outbreaks traced to specific devices, and the most common that we all know about are endoscopes, right? The occasional outbreak traced to improperly reprocessed endoscopes. The solution is to revisit the cleaning protocols and fix the problem with the cleaning. We know that endoscopes can be safely reprocessed. So it's a lapse in the human factor side or in some part of the systemic reprocessing that has failed, that has exposed those patients to risk. The solution should not be a knee-jerk reaction to convert to single use. It's a strange cultural behavior that's unique to Canada and the US and Europe in particular. In Asian literature, they do not have that same response. They alter their cleaning protocols and they find durable solutions. So 100% there's no data in support of improved infection control with single-use devices. And even more than that, there never will be, because surgical site infections are now so low. Our rates are so low, they're under 2% across all surgeries, and obviously variable amongst different types of procedures, that there will never be a single intervention that will be able to substantially reduce that. All of the recent gains over the past 10 years have been multifactorial, like ERAS protocols that are bundles of interventions, and changing a single consumable of the entire operative process will not change the patient factors and everything else that contribute to that patient's infection risk. So we're never, ever going to see good evidence showing an infection benefit.
Excellent. So clear answer on that one for sure. I like it. Here's an interesting comment too. It's an observation that the move towards single-use items seems to have been in lockstep with the siloification of healthcare. Any advice in breaking this cycle?
That's a very astute observation, and there aren't easy solutions to that. It kind of harkens back to the cost question and how we do our accounting, because that siloification applies to budgets as well, right? And the OR budget has to buy the consumables, but some of the consequences of that are absorbed by other budgets. So it kind of requires engaged leadership who are willing to break out of those silos and actually look at the bigger picture and undertake full cost accounting to change those norms. That's all I can suggest.
Yeah, and I think you pointed out right off the bat, there's no time like the present, because we have a real reset and an opportunity moving out of the pandemic. So fantastic. So I think we're just going to wrap up here. So I just really want to thank you on behalf of OAGS and all of our members for delivering a absolutely fantastic keynote. My mind was blown, to be honest, and I learned a lot, and I got to think about how I'm going to start improving our ways, at least in our operating rooms, for sure. So I really want to thank you, and I look forward. It looks like you're going to be making a tour of Ontario, getting this message out there. So we really, really appreciate it. Thank you so much, and we hope we'll see you again real soon.
Thank you both. It's been a pleasure.
Absolutely.
All right.
Thank you.
Thanks.